Right, good morning, everyone. Chella, let's begin. Today, we're diving into a really fascinating topic, the actual wiring of our body, the peripheral nervous system. Just imagine for a second, it's like a biological electrical grid that connects your brain to every single muscle, every bit of skin. It allows you to move, to feel, to live. So let's get into it and understand how this whole system works, okay?
I'm sure every single one of you has felt this, no? You fall asleep with your arm in some funny position, and when you wake up, you get that weird tingling, that pins and needles feeling. What is actually happening there? Well, that strange sensation is a perfect, everyday example of a temporary nerve signal problem, and it's our perfect entry point into this whole complex world of neurology.
So, before we can understand what goes wrong, the pathology, we first have to be experts in what's right, the normal physiology. So, first things first, let's break down the basic hardware of this amazing system. What are the fundamental parts?
Now, for any movement you make, even just lifting your little finger, you need a team. In neurology, we call this team the motor unit. It's actually very simple. It all starts with one motor neuron in your spinal cord. This neuron sends out a single long cable, we call it the axon, which travels all the way to a muscle. At the very end, it connects to a group of muscle fibers. And that's it, one neuron and the bunch of muscle fibers it controls. This is the basic functional team for every single thing you do.
Okay, let me give you a very simple analogy that will stick in your heads forever. Think of a nerve fiber just like a common electrical wire. The axon, which is deep inside, is like the copper wire itself. It's the part that actually carries the electrical signal. But, as any good electrician knows, a copper wire needs insulation, right? Well, that insulation is the myelin sheath. It's this fatty layer that wraps around the axon, protecting it, and, this is very important, making the signal travel incredibly fast. So remember, axon is the wire, myelin is the insulation. Simple, but absolutely crucial.
All right, now we come to the juicy part, the part that's most interesting for a doctor. What happens when this perfect system breaks down? When you're in the wards, you'll find that pretty much all nerve injuries fall into two basic types. Either the wire itself gets damaged or the insulation around it gets destroyed. Let's look at these two main ways things can go wrong. So this is the crucial point, and pay attention, this is very important for your exams. If the axon, our copper wire, is damaged, we call it an axonal neuropathy. The signal finds it hard to get through, so its strength, what we measure as its amplitude, goes down. But if the myelin sheath, the plastic insulation, is damaged, that's a demyelinating neuropathy. Here, the signal can still get through, but it's not fast anymore. The speed, what we call conduction velocity, slows down dramatically. See? Two different problems, two very different results on a nerve conduction test.
So what happens when that wire, the axon, is actually cut, say in a bike accident? Well, the part of the axon that is now separated from the main cell body, its source of nutrients, it can't survive. It's just going to break down and die off. This specific process of the axon dying back is called Wallerian degeneration. It's the absolute textbook example of an acute axonal injury. Now look at this. This slide is really interesting because we are seeing the direct aftermath. This is what it looks like under a powerful microscope. Once that axon inside is degenerated, the myelin sheath that was wrapped around it, well, it has no job to do anymore. So it starts to unravel and break apart, forming these little fragments and fatty droplets that you can see here. It's basically the microscopic debris field left after a nerve injury.
You know, our bodies are amazing machines. They're always trying to heal. When the myelin insulation gets damaged, special cells called Schwann cells will try to make a new layer of insulation. But just imagine this happening again and again in a chronic disease. This cycle of damage and repair, it eventually leads to a kind of permanent scarring around the nerve fiber.
And this picture, this brilliantly shows the end result of that chronic process. What you're seeing here is a classic onion bulb formation. Right in the center is a single axon, but look at what's around it, layer after layer after layer of Schwann cells. Each one is basically a failed attempt at repair. It looks exactly like an onion that's been cut in half. When a pathologist sees this, it's a dead giveaway for chronic demyelination and remyelination.
All right, so we've understood what can happen to a single nerve fiber. Now let's zoom out a bit. Let's see how all this builds up into the clinical pictures you're going to see in your patients. How does this damage show up, not just in one tiny wire, but across the body's entire network?
Clinically, we classify how the nerve damage is distributed into four main patterns. First, there's mononeuropathy, where only a single nerve is affected. Then, there's polyneuropathy, where many nerves are affected, usually in a symmetrical way. Then we have mononeuritis multiplex, which is a bit random, a haphazard pattern hitting individual nerves in different parts of the body.
And finally, polyradiculoneuropathy, a very serious condition that affects the nerve roots near the spine as well as the peripheral nerves.
Let's just focus on the two most common patterns you'll see. Mononeuropathy is a single, localized problem. The classic example, carpal tunnel syndrome, just the median nerve getting compressed at the wrist, very localized. But polyneuropathy is a widespread systemic problem, and because the longest nerves in our body are the most vulnerable, symptoms almost always start in the feet and then later in the hands. This creates the absolutely classic stocking and glove pattern of numbness and pain. You must know this pattern.
Okay, to make all this theory really stick, let's look at two famous diseases. These are perfect case studies. One is the classic example of a demyelinating disease, and the other is the most common axonal neuropathy you will ever see in your life.
Now, look at this table carefully. On one side, we have Guillain-Barré syndrome. What's the main problem here? It's an acute attack on the myelin insulation. And the key clinical feature? The patient develops a rapidly ascending paralysis, starting from the legs and moving upwards. Okay, on the other side, diabetic neuropathy. What's the problem there? It's chronic damage to the axons, to the wires themselves. And the key feature? That classic stocking and glove sensory loss we just talked about. You see how knowing the pathology helps you understand the disease? It all connects.
So far, we've talked about the axon wire and the myelin insulation. But what about the final point of contact, that place where the nerve signal has to be handed over to the muscle to make it contract? This crucial transfer point is called the neuromuscular junction. It's like the final handshake.
You see, sometimes the entire nerve is perfectly fine, but the problem is right here, at this handover point. In a disease called myasthenia gravis, the body's own immune system gets confused and it attacks the receptors on the muscle that are supposed to receive the nerve signal. So the nerve is firing correctly, it's sending the message, but the muscle just can't receive it properly. And the result is severe muscle weakness that gets worse and worse with use. So after all of this, what is the most important take-home message for you as a future doctor? It's this. To diagnose any peripheral nerve problem, you have to first ask two fundamental questions. Question number one, what is the type of damage? Is it the wire, axonal, or is it the insulation, demyelinating? And question number two, what is the pattern of damage? Is it just one nerve, a mononeuropathy, or is it widespread, a polyneuropathy? Answering these two questions will narrow down your options dramatically and point you right to the correct diagnosis.
And that brings us to the end of our discussion for today. We've seen how this incredible system is built and the different ways it can unfortunately fail. It really makes you think. This complex wiring is meant to last us our entire lifetime. So the final question I want to leave you with is both a clinical and a personal one. How do we as doctors and as human beings protect this vital connection? We'll continue this next time. Thank you.
Namaste, my dear future doctors, and welcome to our session. Today, we're going to tackle a really crucial topic, something you will see again and again in your clinical practice, the pathology of skeletal muscle. This is very, very high-yield stuff, okay? So grab your notes and let's dive right in.
So just imagine this scene. A patient walks into your OPD, okay? He tells you, Dr. Sahib, I am feeling very weak, but there is no pain. Immediately, right away, this one question should pop into your head. Is the problem with the wiring, the nerve, or is the problem with the motor itself, the muscle? Everything starts from here. This is the first, most fundamental question you have to answer.
And this is the core difference we're talking about. See, in a neurogenic injury, the nerve supply is faulty. The muscle is fine initially, but with no one telling it what to do, it starts to waste away. Now, on the other hand, in a myopathic injury, the problem is inside the muscle fiber itself. The nerve is shouting commands perfectly fine, but the muscle just can't listen because it's sick. Getting this distinction right, well, that's everything.
So, our first job as pathology detectives is to figure out how to tell these two apart when we look at them under the microscope. Let's see how we can do that.
Okay, now look carefully at these pictures. On the left, that's normal muscle. See how the dark and light fibers, the type 1 and type 2, are all mixed up nicely, like a black and white chessboard? That's what we want to see. But now, look at the picture on the right. This is a neurogenic problem. What's happened is that some nerves have died, and the surviving nerves are trying to adopt the abandoned muscle fibers. This makes fibers of the same type clump together, and you lose that beautiful checkerboard pattern. We call this fiber type grouping, and it's a huge clue that the problem is with the nerve. So,
For your practicals, for your viva, you must remember these 3 signs. 1. You'll see entire groups of fibers getting small together. We call that grouped atrophy. 2. You'll see that fiber type grouping we just talked about. And 3. The atrophied fibers themselves will look squashed and pointy. They'll be flattened and angulated, not nice and round. These 3 together scream neurogenic atrophy. So please, know them well.
All right, now let's see the other side of the coin. What if it's a primary muscle problem, a myopathy? Well, the picture is much more chaotic. You'll see individual muscle fibers just dying. That's necrosis. But you'll also see the muscle trying to fight back. It's trying to repair itself, making these small, new, bluish fibers. We call them basophilic, regenerating fibers. But over time, with all this fighting and damage, you get scarring, which is endomysial fibrosis. And eventually, the muscle gets replaced by fat. It's like a battlefield right inside the muscle. Okay, now we move on to a really fascinating and very important group of diseases. This is what happens when the body's own immune system gets confused and decides to attack its own muscle. We're talking about the inflammatory myopathies.
Now look very, very closely at this slide, my students. This is a spot diagnosis. You see this, you should immediately think dermatomyositis. Can you see how the muscle fibers right at the edge of the bundle, the fascicle, are much, much smaller than the ones in the center? This is a classic finding called perifascicular atrophy. It is pathognomonic. If you see this, it's dermatomyositis. Simple as that.
And this is where pathology meets the clinic. It's so beautiful. The patient who gave this biopsy, they won't just have muscle weakness. They will also have a classic purplish rash on their eyelids. That's the heliotrope rash. And they'll have these reddish, scaly bumps over their knuckles, which we call Gottron papules. The biopsy is just confirming what you are suspecting from seeing the patient.
Let's look at another one. This is inclusion body myositis. Now, I want you to look right inside the muscle fibers. Do you see those little holes, like tiny bubbles with a reddish border? Those, my friends, are rimmed vacuoles. Basically, it's cellular garbage, abnormal proteins that the cell can't get rid of. Finding these is a very important clue for this disease.
And here is a guaranteed exam question for you, a high-yield fact. If you get a question about an elderly patient, someone over 65, with weakness that has been getting worse very slowly, you must think of inclusion body myositis. It is the #1 most common inflammatory myopathy in this age group. Remember that.
Right. Now, let's completely shift gears. We're done with nerves, we're done with autoimmunity. Now we're going to talk about problems that are built in from birth, genetic diseases, errors in the very blueprint, the DNA that tells the body how to build a muscle. We're talking about the muscular dystrophies.
Now, to understand these diseases, you have to understand one key protein. Its name is dystrophin. The best way to think about it is like a shock absorber in a car. It connects the inside skeleton of the muscle cell to its outer wall. It gives it strength and protects it during contraction. So, what happens if you remove the shock absorber? Well, every little bump, every single muscle contraction causes damage to the cell.
And just look at this. This is how we prove it. We have a special stain that lights up dystrophin. In that little inset box, you see normal muscle. See that beautiful brown line around every single fiber? That's the dystrophin. That's the shock absorber. Now look at the main picture. This is from a boy with Duchenne muscular dystrophy. And it's just gone. Nothing. Completely absent. The shock absorber is missing. This test is definitive. This slide, it tells the whole sad story of this disease. On the left, this is from a young child. You can see the muscle is trying its best to fight. There is damage, yes, but there's also regeneration. But then you look at the right side. This is from an older patient. The battle is over. The muscle is almost completely gone, and it's been replaced by all this white fatty tissue and pink scar tissue. And that is why the patient just gets weaker and weaker over time.
Okay, Beta, pay attention now. This table is extremely high yield. Duchenne and Becker muscular dystrophy. They are both caused by a problem with the same gene. So what's the difference? It's simple. In Duchenne, the dystrophin protein is completely absent, 0. In Becker, you get a shortened protein that kind of works, but not very well. And that one difference changes everything. Duchenne is severe, starts very early. Becker is milder and starts later in life. You have to master this table. It's a guaranteed question. All right, very quickly now, let's just touch on a few other ways muscle can get sick. Because, it's not always genetic or autoimmune.
In your daily practice, I promise you will see patients on statins for their cholesterol who complain of muscle pain. That's a toxic myopathy. Thyroid problems too. Both too much and too little hormone can cause weakness. And then you have these rare inherited diseases where the muscle just can't use its fuel, fat or sugar, properly. And sometimes the issue is with the powerhouses of the cell, the mitochondria. When the mitochondria are faulty, they just start clumping up right under the cell membrane. And when we use a special stain, we see this really striking picture. We call it a ragged red fiber. When you see this, you know you're dealing with a mitochondrial myopathy, a problem with energy production itself.
You know, for so many years, all we in pathology could do was describe these awful diseases. But now we are entering a new era. For the first time, we are learning how to actually go in and fix the problem at its source. Let's talk about the future.
And the idea, it's actually beautifully simple. Step 1, you find the broken gene, like the dystrophin gene. Step 2, you take a harmless virus. Think of it like a tiny delivery truck, and you load it with a correct copy of the gene. Step 3, you inject this, and the virus delivers the correct blueprint to the muscle cells. The cells can then start making the protein they were missing. And you know what? This is not science fiction anymore. This is happening today.
So I want to leave you with this thought. We started with a simple question, nerve or muscle? And we've ended up here, talking about rewriting our own genetic code. As you all start your careers, you will be the ones using these incredible new tools. You are the future of this revolution in medicine. It is now in your hands. Thank you very much.
Hello, everyone, and welcome back to our Pathology series. Today, we're tackling a very important topic from Chapter 27, Peripheral Nerve Sheath Tumors. I know. These names can be a real headache, especially in your vivas. But don't you worry. By the end of this session, you'll have everything crystal clear. So, let's start, shall we? Yes, these three, the usual suspects, right? The examiner puts up a slide, asks you to identify it, and suddenly your mind goes completely blank. Is it a schwannoma or a neurofibroma or, God forbid, the dreaded MPNST? Okay, relax. We're going to clear up all that confusion today so you can answer with 100% confidence. So first up, we have the most, you could say, well-behaved tumor of the lot, the schwannoma. Just think of it like the class topper. It's benign, meaning it's not cancerous, and it stays neatly in its own place. Okay, now what are the key things to remember? It's a benign tumor, of course, coming from Schwann cells, but the most important feature, the one you must remember, is that it is well circumscribed and encapsulated. It has a nice capsule around it. Now, why is this so important? Because it means the tumor just pushes the nerve aside, it doesn't grow into it, so a surgeon can often just shell it out without damaging the nerve. Also, please remember its association with neurofibromatosis type 2, or NF2, and the good news, it almost never ever becomes malignant. A favorite question for the examiners is its most common location, and that is the cerebellopontine angle, where it's attached to the vestibular part of your 8th cranial nerve. This is exactly why patients will complain of tinnitus, that ringing sound, and hearing loss. Now, for years, everyone called it an acoustic neuroma, but please, beta, do not use that term. It's a double misnomer. It's not from the acoustic part of the nerve, and it's not even a true neuroma. The correct name is vestibular schwannoma. You have to remember that. Right, let's look at the histology. Just look at this slide. It's beautiful, no? You can clearly see two different patterns. This dense, very cellular area is what we call Antoni A. All the tumor cells are packed tightly together. And then you have this looser, less cellular, almost watery-looking area. That is Antoni B. This dual pattern, this mix of Antoni A and B, is super characteristic of schwannomas. But wait, look closely inside the Antoni A areas. You can find something even more special. And there it is, the Verroque body. If you spot this in your practical exam, jackpot. You can confidently say it's a schwannoma. Just see how the nuclei are lining up in these neat rows, almost like soldiers on parade, eh? And in between these rows of nuclei, you have these pink, empty zones with no nuclei. This whole structure is a Verroque body. It's a dead giveaway. You cannot miss it. All right, next up, let's talk about the neurofibroma. Now, if the schwannoma was our well-behaved class topper, the neurofibroma is, well, it's a bit more messy. It's also usually benign, but, and this is a big but, it is not encapsulated. It grows within the nerve itself, mixing with the nerve fibers, which makes it much more infiltrative. So, neurofibromas come in a few different types. You have the superficial cutaneous kind, which are those little fleshy nodules on the skin. Then there's the diffuse type, which can form a big raised patch on the skin. But the one you absolutely must pay attention to is the plexiform neurofibroma. This is the one that grows within many nerve bundles at once, and it has very serious implications. And here is the most crucial point. the genetic link. While you can see other types pop up randomly, the plexiform neurofibroma is what we call pathognomonic for neurofibromatosis type 1, or NF1. When you see one, you must think of the other. This is a vital connection to make, not just for your exams, but for your entire clinical career. Now, to help you remember what it looks like grossly, here's a classic description. It's a bit graphic, but you will never forget it. Because the tumor grows within and expands all these nerve fascicles, it creates this tangled, ropey mass that surgeons say feels like a bag of worms. It's a very vivid and, memorable description. And have a look here. This is exactly what we mean. Each of these big, roundish structures is a nerve fascicle that has been totally expanded and infiltrated by the tumor. Now, you can imagine how a whole mass of these would create that bag of worms feeling. It's completely disorganized, infiltrative, totally different from our neat, encapsulated schwannoma. Okay, so what about under the microscope? If schwannoma has its Verroque bodies, neurofibroma has its own special feature too. We have another food analogy for this one. The wavy collagen bundles inside are often described as looking like shredded carrots. It's another excellent visual to keep in your mind for the practicals. And you can see it so clearly here. See these wavy pink collagen bundles mixed in with all the spindle cells? They really do look like shredded carrots in a salad, no? It's much less organized than that dense, untani A pattern we saw before. It's much more delicate and wavy. So if you see this, your mind should immediately go to neurofibroma. Okay, take a deep breath. We have covered the benign tumors. Now we must talk about the villain of this story, the malignant peripheral nerve sheath tumor, or MPNST. This is a high-grade sarcoma. This is cancer, and its behavior is aggressive and very, very dangerous. Unlike the others, an MPNST is poorly defined. It has no respect for boundaries. It infiltrates aggressively along the nerve, and it invades into all the surrounding soft tissues. Microscopically, you will see all the ugly features of malignancy. You'll see cells dividing like crazy, which are the mitoses. You'll see areas of cell death, which is necrosis. And you'll see anaplasia, which means the cells just look bizarre and all different shapes and sizes. So, now do you understand why that plexiform neurofibroma was so important? Because this is the biggest risk. The lifetime risk of an NPNST developing in a patient who has NF1 is about 5 to 10%, and it almost always arises from a plexiform neurofibroma that has turned malignant. This is a life-threatening complication. Whew, we've covered a lot of ground. So now let's get to the most important slide of this whole talk. This is your high-yield summary, perfect for that last-minute revision just before you go into the exam hall. Let's put everything together. Let's just quickly break it down. Schwannoma, benign, encapsulated, linked to NF2, almost zero malignant risk, and the key histology is Verroque bodies. Got it? Good. Next, neurofibroma, also benign, but unencapsulated, linked to NF1, has a low malignant risk, but only in the plexiform type, and the histology shows shredded carrot collagen. And finally, MPNST. This one is malignant, poorly defined, strongly linked to NF1, and its histology is ugly, showing anaplasia and mitoses. Beta, you must screenshot this, write it down, burn it into your memory. This table is everything. So I will leave you with a final thought, something to connect all this pathology back to the real world, to the clinic. Based on everything we just talked about, encapsulated versus infiltrative, benign versus malignant, how do you think a surgeon's plan would change for each of these tumors? Think about it. Understanding the pathology is always the first step to making the right decision for the patient. Good luck with your studies, and I will see you in the next one.